So we are good to go very soon. Welcome, my dear audience and friends, to Cancer Convos with Grace B. This is your host, Grace B, coming to you from New York City, the city that never sleeps and is home to Cancer Convos with Grace B. I'd like to thank you guys ever so much for your continued support on my platforms. For the newbies, this show aims to demystify the cancer disease and to bring experts and stakeholders in the cancer space to come give their take. It's Cancer Screening Week, and don't forget to do your screens. And as we all know, until there's a cure, prevention is the cure. Now, as a breast cancer survivor, I constantly come across female cancer patients of childbearing age who have not, unfortunately, had children before their cancer diagnosis and regret not having the opportunity or not having available information as regards fertility options. Now, this breaks my heart. Being a mother myself, I had to invite a very fantastic man with a great mind to come give evidence-based insights through this very complex situation. My next guest will guide us through this. He is a Nigerian obstetrician and gynecologist and the managing director of Nordica Fertility Center, Lagos, Nigeria, which specializes in IVF, which is in vitro fertilization, and treatment of infertility. He's a passionate infertility expert who has written countless medical articles and a philanthropist. If I had to list all his achievements, believe me, we would be here for a very long time. Therefore, without much ado, let me welcome Dr. Abayomi Ajayi to the show. Welcome, Dr. Ajayi. I'm so honored to have you with me. Thank you for coming.
Thank you so much, Grace, and thank you for the wonderful intro.
Thank you, sir. So please, sir, I know, that intro was too brief. Please go ahead and tell us about yourself, childhood, school, family.
Okay, yeah, thanks. Yes, I was born in Lagos about 59 years ago, and I attended CMS Grammar School here in Lagos, and for my medical degree, my first degree was in the University of Lagos, and then I did my postgraduate training at the University College Hospital, Ibadan. And since then, I worked in Laguna Hospital when I became a gynecologist, and then I set up Nordica Fertility Center in 2003. And so that's family. Okay, I have 4 children, and I'm expecting my 4th grandchild.
Oh, and congratulations!
Thank you. So yeah, that's the bit and pieces of it. Yeah.
That's fantastic. Dr. Ajayi, as MD, CEO of Nordica Fertility Center, which happens to be a very, very reputable fertility center, I would also love to congratulate you on your amazing milestones, bringing smiles to the faces of families over the births of so many children, beautiful children. So your remarkable institution has brought smiles to those who had lost hope of ever having a child. So before we delve deep into what you do and all that at the center, please explain to us exactly what infertility is and what causes this medical condition, please.
Yeah, thank you. Infertility is the inability of a couple to conceive or have a live pregnancy baby after 1 year of trying. There are 4 major reasons why this could happen. either the man, which we call male factor, or the woman, which we call the female factor, or the two of them together, which we call combined factors. And then there's a small group which is about, depends on the environment, between 10 to 20% of the time, which we call the unexplained factor. What this means is that after doing the common test for infertility, we can still not find out why this couple is unable to have children. Now, what I tell my patients most of the time is that doctors don't treat test results. Okay, even if the test result says there is no reason, but this couple have been trying for 2-3 years, then there is a reason which your test results probably cannot find. And so they belong to that unexplained group. Of course, if we do some other very fine test, you might be able to find some of the reasons. But sometimes we ask ourselves, except for research purposes, why do you want to do those tests? Okay, because they don't add to your treatment of the couple. So yeah, but so that's where the unexplained group comes in.
Okay, sir. So how long does one have to wait? You said 2-3 years. So many people or couples that I've seen and read about have actually gone on to wait for much longer before seeking intervention in this regard. But from your medical perspective, how long do you think a couple should wait before seeking help in that regard?
Actually, another wonderful question. We don't even have the luxury of 2 to 3 years. Actually, when you asked me what infertility is, I said it's the inability to have a child after. So actually, it's 1 year if you are less than 35. But if you are over 35, especially the woman, if she's over 35, then 6 months after 6 months, you should start knocking on doctors' doors to be able to find out, is there any problem? Because we know that infertility also is dependent on the age of the couple, but more especially of the woman. So, once after 1 year of trying, when we say you've been trying, that means you are having 2 to 3 intercourse in a week, unprotected intercourse in a week. Then you should be seeing the doctor.
Okay. Oh, wow. That's fantastic advice there. So now back to what you actually do at the Fertility Center. What is IVF? And could you please walk us down this process, please?
Thank you. Yes, I will. IVF, like you said in your intro, means in vitro fertilization, which means fertilization taking place outside the body. Okay. This method was the first successful one was in 1978, and since then, millions of babies have been gotten through the process of in vitro fertilization. Now, the process involves when you have done your investigations and then you have seen that, okay, the best way to treat this couple is through IVF. Then there are probably 4 or 5 steps involved. Okay, then that's the first thing is that we need a woman normally will produce 1 egg in a month, but it's not only 1 egg that started the journey, but there is a process in the body that makes only 1 egg to come out to maturity. So the first thing we need to do is to suspend that system in the body with a drug, and then so that we can recruit more eggs in that cycle. So the first drug suppresses that process of making only 1 egg to mature. The second drug now stimulates as many eggs as possible to be recruited into that cycle, because we cannot deal with one egg. We need as many eggs as possible. So now we start monitoring these eggs through the scan, the ultrasound scan, and then once we see that they're mature, then we have a trigger injection, which we give to make the eggs to mature. But before the body throws them out, then we have to go there to pick up the eggs. So the second process, after using the drugs to mature the eggs, and then you have triggered the eggs, is to go and pick them up in the laboratory. Now, this pickup is not a surgery as in cutting you open. There's this needle that can be attached to the probe of the ultrasound scan. This scan is done through the vagina, and then we can put the needle through it, and then we can see the follicles which contain the eggs, and then bring them out through the vagina. It takes about 10-15 minutes, and then we're through. The moment we brought out the eggs, we must now give them to the embryologist. This is a scientist that is training, looking after the eggs and the sperm. Mm-hmm. We now, in the laboratory, combine the sperm and the eggs together. Now, depending on the parameters, the sperm parameters, will dictate what the embryologist is going to use to bring the sperm and the eggs together. If the sperm parameters are up to par, then the embryologist can do what we call the conventional IVF, which is like boy meets girl in the laboratory. Mm-hmm. The sperm and the egg will have a way of talking together. Mm-hmm. But the sperm parameters are subpar, then the embryologist does what we call ICSI, or intracytoplasmic sperm injection. Now, what that means is just that the embryologist will identify one sperm and inject it into the egg. Okay. That's what we call ICSI. So, depending on what the sperm parameters are like, then we determine what is the best way to bring the sperm and the eggs together. So what we're just doing, in actual fact, is what nature does, bringing sperm and egg together. And now we must do it in such a way, though we're doing it outside the body, that it must mimic the conditions in the body. So the incubator where we're going to put the sperm and the egg to mix is set at body
temperature
and carbon dioxide,
Okay.
So which is like in the body. So, and once we do this, the egg will continue to grow. The fertilization, after fertilization, the egg will start splitting or dividing into parts. And so with the embryologist, will start looking at this and see that they're progressing normally. So you can do your transfer either on the 3 or the 5, all right? And so, and also, so now we can even decide not to transfer in that cycle. We can keep and then transfer at a later date, depends on. But after your transfer, you now wait for 2 weeks in order for you to do a pregnancy test. And that's where you know whether you have succeeded or you have not.
So, Dr. Jai, when you talk about transfer, that is transferring the already fused embryo back into the body of the lady, right?
That's right.
That's wow. Right. That is something. That is something. All based on the, what should I say, temperature, body temperature and everything. So
sure.
what could go wrong during this time is if the embryo does not ripen or grow to what are those instances that could make it not be successful?
Okay. Many things could go wrong during this process if you look at it from the point of view. For example, the woman might not produce enough eggs.
Okay.
All right. Or she might even have no eggs at all. That's why the counseling is very important. Before I spoke to you now, I was just talking to a couple. The woman is 48 years old. She wants to use her eggs. All right. So it's that kind of situation. You might end up having no eggs at all. And that will, the process will stop at that stage. Right? Mm-hmm. But sometimes even you get the egg, you get the sperm, because either the egg is not very good. The greatest reason why that might be so is age. Right? The commonest reason why that might be so is age. So if it's not very good, and then the sperm cannot fertilize it, or it fertilizes and then it dies prematurely, there is nothing for you to transfer. That's also a possibility. The process also stops at that point in time. So, but if if everything is working out well, we expect that about 70 to 80% of the eggs that we bring to the laboratory will fertilize.
Okay. Right?
So, but now the biggest problem we have where things really go wrong is after your transfer. that the body now only takes about maybe about 40% of what you have transferred to it. So, and that's, so the failure really and truly, the rate limiting process in IVF is what we call implantation, okay, which we actually refer to as the black box of reproduction, because we know very little about what is happening at this stage, because it's like you planted a maize, you can't go there to scratch to see whether it's growing or not. You have to wait for it to sprout. And so that's what the 2 weeks is all about. We wait for it to sprout and then see whether we have succeeded or we have not succeeded.
Okay, doctor, that's so interesting. You know, the way you've actually explained it. I mean, I've read about it and all that, but you've really taken time to really explain all these questions that I had wanted to ask. Now, I know every woman is desirous of having, you know, children and all that, but I do read in certain places that not every woman is considered a candidate. What does this mean?
Well, you see, reproduction has two phases. There is the fertilization and then there is the implantation. Okay. Sometimes you can see from the get-go that, for example, if a woman is no longer producing eggs, just like we said, okay, there is nothing for you to fertilize. Okay. So, but of course, such a woman can use donor eggs, all right? So it's not no for such a patient. Okay.
Yes.
But most of the time, the problem is with the implantation, where the woman's systems now interact with the embryo. Okay, for example, for a woman who we know that, for example, has cardiac conditions that are severe, you might not want such a person to get pregnant.
Okay.
Uncontrolled hypertension, uncontrolled diabetes, they might not just be people that you want. Or she's had repeated surgeries that we see that the uterus, it's not really very good to be able to encourage implantation. You know, you try to do what we call hysteroscopy, that's looking inside the uterus, and you see that the whole place is scarred, especially in our environment, where we see that many people, up to about 80% of women by age 50 will have fibroids in different shapes and sizes. So that might just, and some women have had 3 attempts at surgery, for fibroids. Some of them have ended up with horrible scars, not outside, but inside the uterus. You know? So such people also it might be difficult for them to be able to do IVF. So, but also there is always something for everybody. So such people can do surrogacy. Also, another woman can carry the baby for them. So they're different things. They're different, and the necessity is just the mother of invention.
It's so true.
You know?
Yes.
Yeah. So because of the conditions that we come across, we have been able to get so many methods that could help. And also, for some people, you know, I'm sure you know that now it's possible to do some genetic screening for some aspects of breast cancer.
Yes,
the ones
sir.
with BRCA.
Yes.
So it's possible also to do that. And you can do that up to the embryo level, where you can choose embryos that don't have antigen. So there's so many possibilities now that we can.
Yes, indeed. I mean, those instances that we would have given up hope for, we now see that there are openings. You know, clinical trials are occurring every day. Research is going on, and really opens up the space for things like this. Interesting. So how long does this IVF process take, actually?
Yeah, well, it depends on the kind of treatment that one is doing and the protocol that is being employed. But generally about 2 to 4 weeks. So it depends on the kind of treatment you're doing. But generally about 2 to 4 weeks.
So what are the things that, if I was seeking, you know, fertility treatment and all that, what are the things that you'd advise me to not to do or to do? First of all, what would you advise me to avoid doing before embarking on an IVF treatment?
Yeah, great question. I think what everybody agrees on is the probably the influence of stress on your outcome. Okay, so probably things that just live your healthy, normal life. Your body mass index should be as near to normal as possible. Okay, so that means your diet. You need to avoid alcohol. I mean, excessive alcohol. If you are smoking, please try to stop. And this time, no recreational drugs. Such are the things that just to lead a healthy lifestyle and your balanced diet. Those are the things that will just encourage you to do. But really and truly, it's just living a healthy lifestyle. So yes, people talk about diet. There is neither here nor there. There's Mediterranean diet. Well, I think it's still all part of living a healthier lifestyle. Okay, because most of the things about diet and no diet is usually most of the time it's not evidence-based per se.
Mm-hmm.
It's really difficult to talk about diet. Yeah, but some people talk about also pineapple, taking pineapple when you're doing the process. But stress is one thing that everybody agrees on. And that's why some people are putting some ancillary treatments like acupuncture, to help when you're doing the treatment. So that all to just in the bit to help you to relax.
Yes.
So I think you can't go wrong with relaxation.
Yes, especially when the lady is anxious, the couple is anxious. There's no way stress or anxiety will not be part of the mix. I would be, because you're like, oh my God, is it going to work? Is it not going to work? Blah blah blah. So you're talking about the woman now, the things that she must avoid. What about her partner, her spouse? Are there things that he should also avoid doing?
Yeah, almost the same thing for the spouse, because don't forget that reproduction, or even IVF, which is reproduction also, is bringing the sperm and the eggs together. So if you have beautiful eggs, you have ugly sperms, you're going to end up with an ugly embryo.
Yes.
So, and that's one of the problems we're having now, because a lot of guys are on some funny things,
Mm-hmm.
And that's also affecting our results.
Mm-hmm.
So it's one of the things we tell them. And sometimes they don't volunteer this history. It's only when you have a failure that the wife comes to you and says, that my husband is doing this, is doing that. And then, so it's one of the things that we need to get out there, that it's one of the sacrifices you might need to make when you have this treatment. So, or just before you start having the treatment, for the sake of even the baby or babies that you're going to produce.
Yeah, that's fantastic. So before this process starts, I take it that you would have called both, husband and wife, or, the couple, to sit down and have a deep, in-depth conversation about what they have to do, counsel them before time, so that they do understand that this is not just about you being the doctor so that they don't blame you. It also has to do with them also committing to the cause.
There is no part of medicine where the patient is involved as in reproductive medicine, because what we say to our patients is that we are not with them 24 hours of the day. Mm-hmm. So they need to understand some of the things. Okay, for example, they need to know when things are going wrong and when things are going the way they should go. So counseling is a very important aspect of. So apart from the doctor counseling them, we have fertility counselors. Some of our clinics also have fertility coaches. So
nice.
Because we know that you need to be in the group for us to be successful with this. Apart from having acupuncturists, some of us also do that. So the idea is that we want, and we, in this environment especially, we don't talk so much.
Mm-hmm.
We talk about things that are not important, but the very important things, we don't talk so much about them. We think they are private or whatever. So it's like you need to try to get things out of these people in order for them to be able to succeed in the endeavor that they. Many people just come to the fertility clinic, especially in this part of the world, not even understanding what the process is all about. All they just want is that I want a baby.
Mm-hmm.
And I said, oh, it doesn't work that way. You need to know the technology. You need to know the limitations of the technology. Because it's like I want to come to the States now and I go and buy a car.
Mm-hmm.
Okay. Well, the money I should go and used to buy a flight ticket. If I buy it, it's going to take me 1 year to get
yes.
to get to the States. So you need to know the technology that is appropriate for the problem that you have to start with. So, and that's one of the things that why counseling is really very, very important. But again, in this part of the world, religion is also a big factor.
Yes.
So most of the time, the people are not even listening to you. And when you say something, they say it's not my portion.
Yes. Yes. Honestly. I talk about that all the time, religion and culture.
Yeah.
You're not supposed to talk. You're not supposed to say anything. But this is my body. I should have a say. I should ask questions.
You should ask questions, and rightly so. Yeah, so that's what we're trying to get people to understand now.
Mm-hmm.
You can't just sit in front of me and tell me that, oh, doctor, you are the one who knows the best. No, I said, no. Now, in this case, it's your body we're talking about. And therefore, you need to be part of the decision making. You need to make the decision. I'm just part of the decision making. I'm supposed to help you in arriving at a decision that you think you are comfortable with.
Exactly. Wow, this is very interesting. Thank you so much, Dr. Jai. Now, this procedure, I know a couple of people that have done it and have, ended up having triplets and quadruplets and all that. Does this IVF procedure, is it actually that it increases the chances of having multiple births? I mean, embryos?
Yes, but it's that's actually, I know in Africa we like multiple births, okay, but it's actually mixed blessings, because we know that when you have more than one baby in the uterus, the chance of complications is higher, all right, and therefore, yes, before up to about 25% of babies born from IVF used to be more than one, but that is reducing worldwide now, because even in some countries now, it's made compulsory that you can only transfer one embryo. All right. So because before we were transferring many embryos, and sometimes the story is told of some people who have transferred 6 embryos in the past, many years ago.
Wow. 6.
Probably before Abraham.
Wow, that's a lot. So.
Yeah. But even it's happened in America.
Yes, I know.
So,
7, 10.
But now, yeah, exactly. But now everybody's going, we know that the technology works. We know that we can, and therefore there is no point in trying to transfer so many embryos anymore. So majority will transfer not more than 2 embryos now. So that has reduced the incidence of multiple pregnancy. But it's still more, IVF predisposes you more to multiples than natural birth. There's still no doubt about that. Because even sometimes you transfer one, is rarely it happens that one splits into two babies. So sometimes that also can happen. So yes, there's the risk, the multiple pregnancy is one of the risks of IVF.
Oh wow. Yeah. Okay. We will note that down. So as you know, I'm a breast cancer survivor. Luckily, I'm a mom. But during my cancer journey, I met young ladies, beautiful young ladies who had been diagnosed and did not have that option of, especially underserved communities. You understand where access to that type of information is very difficult, especially if you don't have insurance or if you don't have a good disciplinary medical team that can show you the way. So I met these ladies, and a lot of them have gone into menopause at such an early age. So for that lady that will be watching us now and all that, what advice would you give to them as to um, questions or options or whatever about having children prior to or after their cancer treatments?
Yeah, thank you so much, Grace. I think I would like to look at this from 2 points, from the underserved areas and the places where medical services are probably done in the right way. I think in places like Nigeria, where sometimes the medical care is fragmented, right? And therefore, you might be talking to a gynecologist who is not even aware that there is something like fertility preservation. And that's where this actually becomes very handy. The knowledge becomes very handy because you could also be asking the doctor about that. Sometimes that's what makes the doctor to start thinking, okay, I'm missing something. Because, the kind of calls I get here, it's like, even when finally the doctor wants to refer the patient, the kind of calls I get is, yes, I have this patient, I'm scheduling for chemotherapy, I'm working out for chemotherapy, I have 1 week, what can you do? And I said, oh no, very little I can do in 1 week, okay. So if in the first place, we can start putting the planning of fertility preservation into the care of people who are diagnosed with cancer, like they will do in the US, for example.
Yes.
That will help a lot. Okay. I think it's easier for places where, like you said, if you have a multidisciplinary hospital where they can, as they're planning about the cancer care, they're also thinking about the fertility, So that might just be a little bit easier, I got a call also from one of the teaching hospitals about a 7-year-old girl, that was diagnosed with cancer. And fortunately, the doctor was already thinking about her fertility.
Oh, fantastic.
Yeah. So, So, because now we know childhood cancers are doing much better than what they were doing before. Unfortunately, most of the therapies will probably render these girls infertile over time.
Yes.
So, and that's also a very important aspect of cancer care, that we should start thinking of when these young girls survive the cancer, that they can still retain their fertility. And so that makes it very, 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 very important. So I think so anytime I see your crusade or I hear about your crusade, I think I'm always excited about it, that somebody should be talking about this. We should bring in this to the fore. And probably also that will help people who are going to go through this struggle. Because it is a matter of when, it's not if. So we have come to live with cancer in the world. And but there's so many methods now, thankfully, that are available for preserving fertility of women who are going through either if it's breast cancer or some of these childhood cancers. For the childhood cancers, because the majority of these girls have not even reached puberty. So it might be the only method that you might be able to have is to conserve part of the ovaries. Okay, ovarian tissue cryopreservation might just be the method that you want to apply to such people. But for the young women who probably are not married and also want to preserve their fertility, fortunately also now we can store eggs. So so that's from 7 years ago or so, we've been able to store eggs, which was experimental in the years of yore. But for the married people, we could always store embryos. So, but even if you are not married now, you can store your eggs. So And there's some other things that we can also, ancillary things that we can do to help such people. For example, if you're going to go through radiotherapy, it's possible to do a surgery that we call transposition to change the position of the ovaries.
Transposition.
Transposition.
Okay.
Change the position of the ovaries to take it away from the full blare of radiotherapy. Yeah, and then we can also they do shielding of the abdomen so that you don't irradiate the ovaries so much. But these are not frontline methods. They are probably ancillary methods. And also for people with breast cancer, also we know that we can do them generally channel. We call it Zoladex here. You call it Lupron in America. It's also possible. That cannot be used alone, but there are things that can also help in preserving fertility in this women. So there are so many things that are possible now in the moment, that are possible for us to use.
Yes. That's fantastic. And like you rightly said, this information should be available, for people to actually know that there are options to be able to, because I mean, if I don't read, I don't know. So even if my doctor doesn't tell me, I'll go to him and say, doctor, this is what I read. How possible is this to be done? That's why health literacy is very, very important for people to actually know that, oh, maybe the doctor is not telling me something, but I've heard somewhere, I've read somewhere, I can bring it to him. Then he can now start, maybe calling in one or two other medical professionals to help him out, people that are well versed in that area as well, know.
I guess that's why the best doctor now is Dr. Google.
I tell you, Dr. Google, Dr. Google is massive, I swear, because all sorts of, I mean, yes, because I even read your articles, Dr. Jai, on Dr. Google. Your articles pop up. And the ones that you haven't told me about, I've already read them. I had to do my homework before bringing you on. So wonderful. Thank you very much, sir. So one thing I know is that in this part of the world where I am, IVF is very expensive, and I can imagine that it is very expensive everywhere. But thing is that in certain cases, they could be covered by insurance, or you have affluent people who, can afford these things. But in your case, and definitely you have patients that have probably, I wouldn't say patients, they're not ill, but clients who would come to you to say, oh, they can't afford this is very expensive. How do you kind of help alleviate that financial burden on them? Because you, as a passionate infertility expert, you want to see their dreams come true. So how do you help them? Do you help them?
Thank you, Grace. That's another wonderful question. You see, sometimes you are torn between two worlds, in the sense that we're in business, and you've just painted another scenario that touches on your humanity. So sometimes it's tough, and but the good thing in Africa again is that because childbearing is a premium in this part of the world. So it's not unusual for you to see family members coming together to help somebody in need, to fulfill their wishes.
Yeah.
We also have some programs, okay, that we have to be mindful, because we also have to pay bills, a lot of bills.
Yeah.
And people don't even know that it's more expensive to run an IVF clinic in Nigeria than, for example, in New York.
Yes.
Because I have to provide my own power. I have to import everything that I'm using.
It's an industry.
Yeah.
It's like production. It's like manufacturing. You have to do everything
It's not
yourself.
like, it's not like,
It
it is.
is. It is. That's what I meant to say. I'm sorry. It is. It
Yeah.
is.
So in each of the clinics, unfortunately, we have 3 different generating plants.
Wow.
Yeah, we need to, because power is so important to what we're doing. So that makes the cost also expensive, cost of production to be expensive to us.
Yes.
Now, then don't forget again that because we have to import everything that we're using, whenever we want to make a purchase from outside Nigeria, I need to make about 460 naira to $1. So that also is a killer, and
Yes,
people don't see, they don't understand all that. And so, but still, you live among people, you live with people who sometimes cannot afford anything. And there is no insurance company that now is going through that hog with anybody. So it's like a personal cross in this part of the world. You have to bear it all on your own. Mm-hmm. Almost everything is paid out of pocket. So that we also understand that. So clinics now have to come with some ingenious ways to see how people can afford this. So one of the things that we have done in my clinic is, apart from giving free IVF clinic treatment sometimes when we can, collaborating with some other people who have like minds, we also do what we call the flexi pay, where we can say you can pay over a period of 1 year.
Flexi pay, right?
Flexi pay, yeah.
Okay. So, I need to put that in my notes so that when I'm talking about this, they know that that comes in. Oh, that's great.
So Nordica flexi, so you can pay over 1 year. Once you've started the process, any price increase would not affect you, and you can pay over 1 year. So we're doing something like that. But also there are some banks, financial institutions that are also giving some loans with very low interest rate now for the treatment of infertility. So those are some of the things that, and then we have one here and there. Okay, like we're involved with Itwa, Mrs.
Igodalo.
Mrs. Igodalo, who just
passed on.
For 40th birthday, said she was going to give 40 people 3 IVFs. So we are also involved with that. So we try to see people with like minds and then try to see how we can make life easier for the people. Because right now we know that it might be difficult for government to be able to take this on. So the appeal would just probably be to see, and then one of the banes of healthcare in this part of the world is that it's left for doctors to sort out. But what I say that healthcare is more than what doctors can sort out. Just like it's an industry, okay? And then when it's something that an industry, some people need to be able to invest in it, but it needs to be able to, the return on investment needs to be able to make sense to it, and so on and so forth. I think that healthcare is just a diamond in the mud in this part of the world that needs to be discovered. So I think over time, we're going to get there.
By the grace of God, I hope so, because, I see our budget for healthcare go down gradually in Nigeria. I mean, before it used to be tops. At that time, it was important. It was at the top of the list. But now I don't know what's going on. When we had, I'm sorry to say, but these things have to be said. When we had real, professionals at the helm of affairs, that actually knew and know exactly how the poor man was suffering as regards health care. But like you said, we keep our fingers crossed. We will get there. We will get there, I'm sure. We'll get there.
Yeah, I think you touched a very important point about, the African countries met and decided that 15% of the GDP should be allocated to healthcare. Nigeria is doing less than 4% now. So, because now most African countries depend on financial assistance for their healthcare, and that cannot work. And that's why healthcare is suffering. But if you ask me, I think it's also a wonderful opportunity for investors to invest in this part of the world. See, it's like telecoms. It's an industry. It's like telecoms.
It is.
You know, when telecoms first came into Nigeria, many companies they missed out on it because they were looking at the difficulties.
And they were looking at short term, they weren't even looking at the bigger picture.
No, they were not. It was only, you can see the companies that braved it. See Nigeria is the biggest mine to them now. So it's the same thing. That's the same thing that's going to happen to healthcare. When finally some people are able to brave it and come around, then they will be asking themselves, why did they not see this 10 years ago?
Mm-hmm.
So we just keep our fingers crossed, just like you said, but I think it's something that is waiting, but it should be done properly. And like you said again, we should look at the long-term effect, not the short-term.
Yes.
And that's what many people investing in Africa are beginning to realize now, that if you want to invest in Africa, don't call for the short haul.
Mm-hmm. Mm-hmm. Nothing is short in Africa.
No.
This is not you have to really wait and see returns.
It's not microwave.
It's not microwave. It's not microwave. You have to boil it forever. honestly, that is it's something that healthcare. I've always been fanatical about healthcare, even before my cancer journey and all that, especially women living with uterine fibroids and having to undergo all that, and and deceiving themselves that they were pregnant to even their spouses, trying to cover up. That's where the culture comes in and all that. So but they say, Sister Grace, you know how much this thing is now. I got a manager. I got to go. But you're bleeding to death. So these are things that we honestly need to.
Now that you mentioned fibroids, we're bringing something in now. We're actually in January that you will not do surgery to treat uterine fibroids.
Oh, fantastic. Fantastic. Dr. Ajayi, you have to tell me more about that so I can.
Yeah, it's called high intensity frequency ultrasound. So it's like burning off the fibroids.
Okay.
And no scar, nothing at all.
Oh, fantastic. Because so that is done internally, right? It'll be like a high frequency thing. Will it have like a probe to do that?
No. It's a probe, but it's placed on your abdomen. It's not
internal.
No.
Seriously? That's fantastic.
Yeah, it's wonderful.
Oh, wow. Okay, we'll talk more about that. So I forgot to ask you, when going through this IVF process, are there any side effects that one should watch out for?
Yes, I think, fortunately it's getting less now. The greatest problem with IVF is the drugs that we use to bring out the eggs. Just like we said, that you need to produce many eggs. Sometimes these eggs really become problematic in that they produce too many eggs, what we call hyperstimulation. And that probably is the only thing that is really dangerous in IVF.
Oh, really?
Yes,
wow.
But right now, we now have protocols that reduce the incidence. For example, in the last 8 years, I don't think I've had any hyperstimulation that will require hospitalization.
Fantastic.
So because that's what we use that regimen more than any other. So hyperstimulation is the greatest threat. So the other things are like, okay, during the process, maybe you can put your needle in the wrong place. That's a very rare thing. Maybe 1 in 1,000 women. So that rarely happens. And
Okay.
good training can always do mitigate that. So those are some of the complications that can arise from IVF.
Mm-hmm. Oh, wow. So, okay, for example, I come to you and all that, and the process has not been successful, and I want to go through it again. Is it necessary? Is it possible? And if it's possible, what's the gap? What is the time frame to be able to start all over?
Yes, now, especially now with the regime that I told you that we can prevent hyperstimulation, you can do back to back if you're ready.
Oh,
So you can,
really?
yeah, you can, the next month you can do it if you are psychologically ready. So the most important thing is, are you set for it? So now, yeah, you can do back to back. You can take some months off. It depends. So there's no tailor-made answer for this. So we have to look at the individual, and some people just say, you know what, I just want to take a break.
Yes.
That's respected. You know?
Yes. And yes, and like you rightly said, they have to be mentally ready, because you say 2 to 4 weeks, but it's a crazy process to
It's forever.
it's
I
having to
know.
go through, and then expectations are high, and then when nothing comes out of it, the disappointment, and having to, and then also the lady is now scared that, oh, maybe it's going to be the same. So a lot of them like fall off the bandwagon and say, no, I'm not going to go through that, because they're scared to, fail at it again, So that's where your coaches and mental health team have to, give them hope too, to say, listen, it doesn't mean because you failed this time, or not that you failed, but it didn't go through.
Yeah.
You can always repeat it,
Correct. That's right. Yeah. Actually, that's the greatest problem in IVF. And sometimes that's also what stands between us and success. Because success rate in IVF is cumulative. Very few people do only one cycle and successful. So you probably need to do 2-3 cycles. And you see some people after one, they just say, no more, It takes them another 2 years to come back. And one thing again is that success rate is age dependent. So you are reducing your success rate again. So it's a lot, and that's why it's so important for the people who are going to go through the process to understand the implication of every decision that they're going to make, so that you can know, okay, you know what, I'm bracing myself for 2-3 cycles. And here we are, we're going to go through it. If possible, I'm going to take 2 months break if it fails before I do another one. So I'm going to take only 1 month. Plan almost everything. And then also, that's when you can also use the support that the clinics have to take you through this period. Because, in Nigeria, counseling is something that is a little bit foreign. The kind of counseling we're used to is the church counseling. The pastor say is the one who tells you what to do. That's not counseling.
At all. At all.
You tell him the problem, he tells you what to do. So they come to the clinic expecting the same thing.
Yes.
But that's not counseling. You are supposed to come with the solution. The counselor is to listen to you, guide you, bring out the solution that is tailor-made for you and by you. And so they fail to understand that. And so they are expecting the counselor to just tell them, oh, this is what you should do. This is what you should do. No, it doesn't work that way. So, and that also makes us not to utilize the counselor properly. But of course, we are getting there. We are better than what we were 15 years ago.
Absolutely. We're getting there. It's not, we just have to take our time. Everything has its You know, as they say, it's not a sprint, it's a marathon.
Precisely.
It takes time to get these things done, you know. Yeah. Dr. Jai, this has been such a wonderful, I could go on and on, but I know that you're up for time. So you're exceptionally busy. You're all over the place, philanthropist, writer, academician, all sorts of things. Where do you find the time to remain grounded? How do you find time for yourself and family? What do you do?
Okay. The funny thing now is that I suddenly discovered my house is a very comfortable place. Mm-hmm. So I spend most of my time now, if I'm not in the office, I'm at home. Because now also, most of my exercise is doing aerobics, mm-hmm. which can be done indoors. You know?
Yes.
So, and that also makes me to, and I, of course, love watching soccer. So, so that's the way I just spend my every day. Once I'm at home, I mean, I've not traveled, which Corona. Oh, and this year has been special.
Oh, special.
I cannot remember the last time I spent so much time at home.
Yes. I know.
It's been great. It's been fun.
You now know all the four corners. You're now discovering places that's
even things I don't want to know about.
You have to know by force. You're indoors. That's so nice, Dr. Jai. Oh, wonderful, wonderful, wonderful. It's been such a wonderful discussion with you. So, if you had to go down this path again, would you?
Yes, maybe with probably one modification. Okay, and that's what is making me to do some things now. I started my life as a doctor. Okay, I'm no longer a doctor, not just a doctor. I'm now an entrepreneur. Okay, and I wish I'd done that when I was much younger, and that's what I think I owe this present generation of young doctors, to be able to add leadership and entrepreneurship to them at a very young age. And that's what's giving birth to what I sent to you this morning.
The mentoring.
The mentoring program. That's essentially what I'm trying to do with the young doctors now.
It's beautiful.
Yeah, doctors have a wonderful opportunity. You know, they are gifted, they are everything, but we're financial illiterate. So it's better that you add financial literacy to them before they really start making money or something. And then also how they can see opportunities. You see, I wonder why everybody wants to go to Canada, everybody wants to go to the UK, everybody wants to go to the US. It's not wise. Seriously. There's so many opportunities in this part of the world. You just need to open your eyes. You just need to understand that every problem presents an opportunity.
Yes.
How do you turn that problem into an opportunity? That's the way we should allow the doctors to start thinking. And that is entrepreneurship, part of entrepreneurship. And so that's what I wish I'd garnered a long time ago. And that's what I think I owe to the younger doctors.
Yes.
To be able to allow them to see that they're sitting, majority of them are sitting on gold, but they're looking for brass somewhere else.
That's a very powerful way of giving back, Dr. Jai, honestly. May God continue to take care of you and open your heart. You've done amazingly well. You know, doing all that you do. In fact, I know you don't want to say too much, but we know who you are and we know what you do. So I really appreciate you coming on the show, Dr. Jai. God bless you for all you do. Thank you so much for supporting Cancer Convos with Grace B.
My pleasure. You're doing a wonderful job too.
Thank you, sir. Thank you.
The good Lord will continue to give you good health and strengthen you.
Amen. Thank you so much for your prayers. Thank you. So before I sign you out, let me say my outro. Okay. So, my dear audience and friends, there you have it. You have been listening to the amazing Dr. Abayomi Ajayi, the MD CEO of Nordica Fertility Center in Lagos, Nigeria. When I post this video, you're going to have all the information necessary for those who would like to know more about what he does and where to go to if they're having any infertility issues. Now, as I always say at the end, don't forget to like, subscribe, and share this channel so that you know that knowledge is power and health is wealth. Thank you guys for always being here for us. Thank you. This is Grace B signing out. Dr. Jai, God bless you. Thank you
And
ever so much.
my pleasure. My pleasure. It's really been wonderful being with you.
Thank you, sir. Bye-bye.
Bye.